చిన్న డోర్ క్లోజ్ చేసుకోండి నాన్న క్లాస్ లో ఉంటారు.
Hello, good evening. Am I audible? Just check my mic.
Yes, yes. You are audible.
Okay, thank you.
Dr. Gauri, do I need to make any other co-host?
Yes, sir. But she has to join.
Yes, sir.
Okay. Yeah.
ఎక్కడైనా కానీ బ్లాక్ పండించాలంటే కదా.
Can we start, Gauri?
Yes, sir.
Please proceed. Whatever you have decided, please.
Good evening, all. Happy to see you all here. A warm welcome to everyone to our webinar series, AGNI, hosted by SHABDHIKA SFI College Union 2021 in association with IHMA Trivandrum chapter. Yesterday, Dr. G. Rajchandra sir taught us about diagnostic methods in case of cardiovascular pathology and was a great session. For those who are joining today, Dr. G. Rajchandra sir is Associate Professor, Department of Practice of Medicine, Father Homeopathic Medical College. His various achievements include Best Outstanding Undergraduate Student 2006 batch, Best Outstanding Postgraduate Student 2010 batch, and First Rank Holder in MD, and so on. Yesterday, we have learned about peripheral examination in cardiovascular pathological cases, and today we will be having continuation of the same topic. Those who have missed yesterday's session, please go through the recording. And hereby, I hand over my mic to Dr. G. Rajendra sir. Sir, please.
Thank you so much, Dr. Akila. Yeah, so on my behalf also, I welcome all the participants who are here. Today we are doing entirely on the white screen, no PPT we are using. So,
Sir, can you just check your voice little bit?
okay. Okay, is it clear? My voice is clear?
Yeah, now it's okay. Yeah, a little bit
Okay.
louder. It's
Okay, yes. Yes, friend. So yesterday we have seen that our patient is here like this. Okay. Okay, this is the foot end of the patient, and right now we are going to start with something called as the precordial examination. When we start with the precordial examination, the first thing is you need to inspect. The first thing is inspect the precardium. Inspect the precordium. So now the most important thing is when we start inspecting the precordium, you are looking for any scars. Okay. For example, if there is any midline scar, particularly on the sternum, it may be indicative of a previous surgery that is called coronary artery bypass graft. Okay. Or parasternal. If it is parasternal, you need to understand there may be possibility of any valvular repair, or it also accounts for any lung related pathologies. Could be a parasternal scar can be seen. Next, along with that, we also need to think about deformity. The deformities that are possible are three types. One is pectus excavatum. Pectus excavatum, also called as the funnel shaped chest. Okay. Next is the pectus carinatum. Pectus carinatum, which is the pigeon chest. Okay. So these are the two important, and there can be also kyphoscoliosis associated. Okay, kyphoscoliosis is generally seen in those patients who are actually suffering with the childhood respiratory disorders. Childhood respiratory disorders are the prime cause for this kind of patient. So now, when all these deformities are there, why are we concentrating on these chest deformities? Because these chest deformities can displace the heart. The heart may not be in its original position. So whenever we are going for palpation, we should be aware of the fact that heart can be displaced. In its normal area, it may not be found. That's why it is very essential for us to identify whether the heart will be in its position or it may be deviated because of this deformities. The next important thing is we also need to check for the pulsations. Okay. The pulsations are going to be important. Yesterday we have picked up something related to jugular venous pulsations. Here also we need to see whether there are dilated veins on the chest, okay, and so on. So these are the important things. So the first thing that we come across here is the inspection of the precordium. Inspection of precordium. So once the inspection of the precordium is done, the second thing that we are interested is to look into the chest, to look on the chest for any impulse. This impulse is also called apex impulse or cardiac impulse. Now, before you actually go to feel the apex beat, please remember, before you go to feel the apex beat, it is also important to see whether there is any cardiac impulse or the apex impulse. Next, the same thing, that is the apex impulse only. Now you can feel it. That is called apex beat. Now, when you talk about the apex beat, let me use a different color to tell you this one. The apex beat, first you should use the entire palm. Okay, your entire hand. Okay, it is generally placed on the chest. Generally placed on chest. Why we are placing it generally on the chest? Okay, because we are not going to specify it. You can place your chest generally on the chest like this, okay, and then feel for the apex beat. You need to feel for the apex beat. Once this generally, once you are keeping the hand, you will get an idea which location you are getting the apex beat. Then we need to specifically feel it. Point number 4 is locate the apex. Locate the apex. Now here when you say locate the apex, here you are locating with the fingertip. You are locating with the fingertip. Come on, this is very, very important. First, you should keep the palm or the entire hand on the patient's chest just to have a feel of the apex beat. Second important thing is, once you know that there is an apex beat, then you need to locate it with the help of your finger. Localizing is very, very important. Healthy individuals, apex is localized. It will not be generalized. It is localized. Okay. Now, once this apex is identified, there are also some abnormalities we need to understand. Apex beat can be absent. Sometimes apex beat can be absent. Apex beat is absent not because the patient is dead or so. Sometimes in case of obesity, if the individual has a thick chest wall, similarly is muscular individuals. Okay. If the patient is very muscular, or if the patient is obese, or some teachers even say that, I didn't find it in the textbook, but some teachers say if the apex is located under the rib, then also it may not be identified. Sometimes the apex is shifted. Like for example, whenever there is a left ventricular dilatation or hypertrophy, okay, in these conditions, your apex may be shifted. Left ventricular dilatation can follow myocardial infarction, or it is part of cardiomyopathy. Okay, or sometimes in case of high preload disorders, any disorder with high preload. Okay, like in case of MR and AR. Let me explain this: mitral regurgitation and aortic regurgitation. So in these conditions, the apex may be shifted. Now, if it is shifted because of left ventricular hypertrophy or dilatation, it will be shifted more laterally, and it will shifted more inferiorly. Please remember this one. Laterally when it is deviated, or inferiorly when it is deviated, the cause could be left ventricular dilatation or hypertrophy. And already we have discussed the different causes of left ventricular dilatation: MI, cardiomyopathy, disorders with high preload like mitral regurgitation and aortic regurgitation. Now we will also think about, for example, there is some occasions it can be shifted more medially. Okay, the only possibility is hyperinflated lungs. Hyperinflated lungs, the apex will be shifted more medially. Hyperinflated lung, two examples: bronchial asthma, another one is emphysema. I think this is more familiar for students, I hope. Okay, in case of emphysema, we use a word called tubular heart. Tubular heart. What is happening to the heart? Heart is being compressed because of the two inflating lungs. Hyperinflated lungs actually can push the apex more medially. So these are the aspects that we should remember whenever we are actually going in favor of thinking about the apex beat. Now, not only this, something else also we need to talk. Apex beat, how is the normal feel of an apex beat? Apex beat is very much localized. Okay. Now, there are two pathologies. I'll tell you, apex is actually contributed by only the left ventricle. Now look at this. For example, let us say this is the apex of the heart. Okay, this is apex of the heart. Now, apex is exclusively contributed by the left ventricle. Now, all the pathologies of the left ventricle, if you remember, okay, the left ventricle can undergo hypertrophy. The left ventricle can also be dilated. Okay, let us draw two diagrams here. So, in case if there is a left ventricular hypertrophy, you see this, what is happening? The left ventricle is majorly hypertrophied in this situation. Okay, I will draw another picture here. Okay, here it is dilated. Now, whenever the left ventricle is hypertrophied, the character of the apex is called tapping. There is a tapping apex, and this is also given one more name. It is called hyperdynamic apex. It's called hyperdynamic apex. But in case if the patient is having a dilated left ventricle, the patient will, the doctor will have a different feel. That's why it is called, it is generalized. See, tapping apex means like this, as if somebody is tapping under the palm. So you'll be able to locate it and the feel is very, very strong. Okay. But when there is a dilated ventricle, it won't be tapping. Instead, it is a generalized feeling, as if the hand is being lifted with each beat. This is called heave. This is called heaving apex. This is called heaving apex. So when you have a heaving apex, okay, it suggests left ventricular enlargement, that is dilatation. So I hope that's clear there. So we move to the next one. So once you have located the apex, what we are doing, we need to assess its character. The fifth point here is assess the character of apex. Yes, so this also we have done. Okay, either it is a tapping apex or heaving apex, we have done it. Now you need to keep the sixth point is keep the heel of your right hand. Most of the people, if they are right-handed, so keep the heel of your right hand over the chest in the parasternal region. This is the next important thing. So we are keeping a hand on the chest, particularly where, you know, the parasternal area. The parasternal area. Now you're keeping the heel. Just look at me. This is like this. Just the heel. Okay. In the parasternal area, just next to the sternum. And now what you're seeing, with each cardiac impulse, whether the hand is also lifted. This is possible in children, not possible in elders. Okay. But it is highly possible in children. Now this is called parasternal heel. Okay, don't get confused. Here we said heaving apex, but here we are talking about parasternal heave. When you say parasternal heave is present, that means the patient is having a pathology that is called right ventricular hypertrophy. Okay, right ventricular hypertrophy causes parasternal heave. Now, whenever there is a right ventricular hypertrophy, mind you, there will be also something called epigastric pulsations. Epigastric pulsations. I am giving you one thing here. Whenever there is a right ventricular hypertrophy, there will be also epigastric pulsations, but I'm not telling you the third one. One more finding will be there. Clinically, one more finding will be there. Anybody would like to help me? What is another finding which can be associated with right ventricular hypertrophy? Epigastric pulsation. Anybody? Okay, that is JVP. Jugular venous pulsations will be elevated. So this is a sign. For example, whenever there is a left ventricular hypertrophy, please remember this, there is a apex impulse. There will be apex impulse, and this apex impulse is going to be a tapping quality. A tapping quality. Left ventricular dilatation, there will be apex impulse, but it will be more of heaving in quality. Okay, but when you have a right ventricular hypertrophy, the first thing is there is a parasternal heave. It doesn't stop there. There will be epigastric pulsations, and also most of the patients will be coming up with a jugular venous pulsations will be elevated. JVP will be elevated. Any questions still here? If no, we will move a little more quickly. So we are now done with the simple method of palpation. Only one thing is remaining for us, that is now it is the time for palpating some thrills. Okay, we need to look for thrill, palpate for thrill. Where you palpate for thrill, we know that we have 4 regions on the chest. For example, I will draw. This is the nipple area, 4th intercostal space, and now this is the clavicles. Okay, yeah, I think that much is sufficient. So let us say this is the 2nd intercostal space. We keep 1 point here. This is the first point, 2nd point in the 2nd intercostal space itself, 3rd in the 4th intercostal space, 5th just below the nipple here. Okay, here. So this area, okay, this is called 2nd intercostal space. 2nd intercostal space. Okay, here is the sternum. I would like to draw the sternum like this. Okay, now sternum, 2nd intercostal space. This margin is called right sternal margin. Okay, the 2nd intercostal space, right sternal margin, is actually the aortic area. It is the aortic area. Now here you see this particular one. This is also the 2nd intercostal space, and this is the left sternal margin. This is called pulmonary area. Now this area, you see this is called lower left sternal margin. Remember this is lower left sternal margin. This corresponds to an area which is called tricuspid area. Now this is another area which is exactly corresponding to the apex. Okay, it is in 5th intercostal space. Okay, 5th intercostal space. If you look from the sternum, it is 3.5 inches. 3.5 inches. Or if you look from the mid clavicular line, 1 centimeter medial to mid clavicular line. So this is the mitral area. So we have 4 areas. One is the aortic area, pulmonary area, mitral area, and the tricuspid area. So what you have to do, you have to place your palm in the aortic area, pulmonary area, tricuspid area, and also the apex. So in all these 4 areas, you need to keep your palm and feel the purry sensation. For example, listen to me carefully here. If the patient is having a murmur, murmur is what phenomena? It is an acoustic phenomena. What is an acoustic phenomena? It is an audible phenomena. Murmur is because of the turbulent blood flow. Please remember this. It is because of the turbulent blood flow. When there is a turbulent blood flow, what happens? You tend to hear the sound. So murmur is an audible phenomena. It is an acoustic phenomena. But if the murmur is highly intensified, that means murmur has an intensity. There are 5 grades of intensity of the murmur. Anything above grade 3, naturally that murmur will be very intensified. And now what will happen? It will be associated with a thrill. It will be associated with the thrill. That means murmur is associated with a thrill. Murmur is an acoustic phenomena. It will be associated with a thrill. Thrill is a palpable phenomena. Please remember, thrill is a palpable phenomena. Okay, so a high grade murmur will have an acoustic phenomena as well as a palpable phenomena. Okay, so how it is, how do you feel that? You know, when you keep the hand over the chest, okay, it feels as if like a purring of a cat. If you have experience of touching a cat, you know, there is a small contractions which take place under the skin of the cat, and so you feel little tickly under your this one. So just like that it will be, and it's very simple to identify. It is a palpable phenomena. Now, immediately when you keep your stethoscope, then you also tend to hear. If there is a thrill, there is no murmur, it is not possible. Murmur will be there, but thrill may not be there. But murmur is intensified, surely thrill will be there. Whenever you feel a thrill, you should be able to hear a murmur also. That means highly intensified murmur will be associated with a thrill. I think that much is sufficient. So next, we move on to the next thing that is called the listening. We are going directly to the listening. That means auscultation. So these are the 7 points on the precordium. So we will just quickly glance through once again. So we are inspecting the precordium for scars, for any dilatation, and also if there is any deformity. Then we are looking for the impulse, that is called apex impulse or cardiac impulse. Then we are actually identifying the apex beat. First, you are identifying the apex beat generally by placing the hand. Then with the help of a fingertip, you are locating it. Okay. Then happens, you have to assess the character of the apex. So what is the character? There are tapping apex and also heaving apex. Now place the heel of your right hand over the chest. Look for parasternal heaving. Is there any parasternal heaving? Then palpate for thrill. That is a palpable murmur is called as the thrill. So I'll clear the screen and now we go for auscultation. Let us see how many points we can describe this auscultation. So now, before, I would like to draw one small picture. Okay, here, this is the neck. Okay, here is the clavicle. And here comes the major blood vessels, the carotids. Yeah. Now, I will be little distant with my explanation. Just say this. For example, the first point here is you need to auscultate over the carotids. You need to auscultate over the carotids. Why we need to auscultate over the carotids? It is because the first point, let's begin with this here. The first point is why we need to auscultate over the carotids or listen over carotids. There are two reasons. One is, just remember, this is the aortic area and this is the pulmonary area. This is the tricuspid area and here is the mitral area, also called as the apex. Okay, this is the mitral area. Now, if you have, for example, listen to me here carefully, please. If you have a murmur which is audible in the aortic area and that is also audible in the carotids, remember this carefully. A murmur is there in the aortic area that is also audible from the carotids. This is actually called as ejection systolic murmur. Ejection systolic murmur of aortic stenosis. Ejection systolic murmur. So what happens here? Actually, murmur is produced from the aortic valve. But what is happening? It is being radiating to the carotids. Location means the best audible site. Location of the murmur is the best audible site. So the location becomes the aortic valve and radiation is the second best audible site. Second best audible site. That means next to the best. After it is audible better in the aortic area, it is also being conducted to the carotids. That's why it is called radiation. This is seen in case of ejection systolic murmur. But you know, one more possibility is there here. That is, the murmur is not audible over the aortic area, but it is only audible over the carotids. Anybody would like to answer this question? The murmur is not audible on the aortic area, but it is directly audible only on the carotids. What is the possibility? There is only one possibility, that is, it is not a murmur, but it is a bruit. It is a bruit. This is called carotid bruit. Carotid bruit. For example, this is the heart. If there is any turbulent sound which is heard inside the heart, it is called murmur. If there is any turbulent sound heard outside the heart, if it is heard in the blood vessel, we call it as bruit. If it is heard in a vein, we call it as hum, H-U-M. For example, you hear it on the thyroid gland. On the thyroid gland also sometimes you can hear because of the hyperemia, congestion of the thyroid gland. Here also it is called thyroid bruit. Sometimes you hear on the uterus because of the excess blood flow to the uterus. Some whistling sound is called. This is called, I think it's called SCHOUFFLE. It's called shuffle. Okay, you try and shuffle, venous hum, arterial bruit, thyroid bruit, all these things. Okay, what is the difference between murmur and a bruit? Both are same. This is also turbulent sound. This is also turbulent sound. But this is a turbulent sound heard within the heart. If the turbulent sound is outside the heart, it is called bruit. There are two classical examples of bruit. One is carotid artery stenosis. Another one is aortic aneurysm. Okay, abdominal aortic aneurysm, AAA, abdominal aortic aneurysm. CAS is carotid artery stenosis. Okay, this stenosis most often it takes place because of atherosclerosis. I hope it's clear. So first one is we are listening over the carotids. What are the two possibilities? Either it can be ejection systolic murmur of aortic stenosis, or it can be because of the carotid bruit. What is the reason for carotid bruit? That is carotid artery stenosis. So now next one, listening over the carotids is over. Now you need to listen over the left axilla. Listen over the left axilla. Why we need to listen over the left axilla? That is because some other murmur may be radiating to this place. Okay, we are listening to the left axilla. You see this? From the mitral area, one murmur can radiate to the axilla. So the name of the murmur is, so the second point in auscultation, listen over left axilla. That means we need to auscultate the left axilla. So here, if you hear a murmur which is radiating, that means the murmur is audible from the mitral area and it is also audible in the left axilla. That is mitral regurgitation. Mitral regurgitation. For this, one small picture we drew and we will explain this. This is aorta. Okay, now just see this. This is a mitral valve. This is the left atrium. This is the left ventricle. This is the aortic valve. Now, what exactly is happening in case of mitral valve regurgitation? See, when there is a mitral incompetence, remember here, mitral incompetence. When you talk about mitral incompetence, okay, what is happening here? Mitral incompetence, the valve is failing to close. Incompetency means failure to close. Stenosis means failure to open. When it fails to close. Now you see, remember this one, when the left ventricle contracts, the blood should go out through the aorta. It should never enter back into the left atrium. That is what is happening in mitral incompetence. So the blood which has come into the left ventricle is now re-entering back into the, see like this, it has come into the left ventricle, but now what is happening? It is entering back into the left atrium. This is called regurgitation. And now when it is regurgitation, just see this arrow mark, it is entering back. So now the blood is moving in the direction of the left axilla. So what will happen to the turbulence? The turbulence also is generated towards the left axilla. Because of the direction of the regurgitant jet, the turbulence also will be more towards the left axilla. That's the reason why we need to listen to the left axilla. In case If the patient is suffering with mitral regurgitation, the murmur will surely be will be radiating to left axilla. So that's the point number 2 in auscultation. Always remember to first auscultate on the carotids, then auscultate on the left axilla. So then the next point is we need to roll the patient to the left side. Okay, there are some specific points that I will discuss in the end, but we will come to the auscultation proper. What is the auscultation proper? Auscultation includes, I will erase all these things. Okay. So now see this here. Auscultation. What is the first point under auscultation? That is, you need to listen to the normal heart sounds. First point is you need to listen to the normal heart sounds. What are the normal heart sounds? One is S1, another one is S2. Okay. So first listen to the normal heart sounds. When you listen to the normal heart sounds, that is S1 and S2. Only S1 and S2 are basically audible in all the patients. Okay. Then you not only hear to the normal heart sounds, first identify whether they are normal or abnormal. Normal or abnormal means S1 is normal intensity, or it is louder, or it is softer, or it is absent. All these things you need to be worried about. Now, generally we say that S2 is because of closure of semilunar valves. S1 is because of closure of atrioventricular valves. Okay, when atrioventricular valves close, S1 we get. S2 is because of the closure of semilunar valve. So generally the normal heart sounds are because of the closure. That's why in McLeod's one point will be there that normal heart valves produce sound only when they close. Normal heart valves produce sound only when they close. It is so specific point for all of us today. Why? Because that point starts with one word that is called normal heart valves. So that criteria is applicable only for the normal heart valves. If the valve is abnormal, it can make sound even when it is opening. So dear friends, I want to remind you, generally heart sounds are produced only when the valves are closing. But opening of the valves is relatively silent. But if a valve is abnormal, it can start producing a sound even when it is opening. Okay. So the first point is you need to listen to the normal heart sounds. Okay. And then the second important point here is, extra heart sounds. Are there any extra heart sounds? Normal heart sounds are S1 and S2. Extra heart sounds are S3 and S4. So here I would like to describe a little bit. For example, this is a cardiac plane. Okay, this is S1. This is S2. So here I will write S1 and here I will write S2. So what is S1? S1 is because of closure of atrioventricular valves. S2 is because of closure of semilunar valves. Okay. So now please try to understand this also. It's a small concept. So starting from S1 till S2, what is happening here? There is a closure of atrioventricular valve. What happens when the atrioventricular valves closes? So if you want to understand this, I would like to repeat this picture once again. See this? This is the left ventricle. This is the mitral valve. The mitral valve is closed. When the mitral valve is closed, just imagine when the mitral valve closes, there is a blood here. This blood has to come out. This blood has to come out. Okay. When the left atrium empties its blood into the left ventricle, When the left ventricular filling is complete, then what happens? This particular valve closes. When the mitral valve closes, we get the sound that is the S1. Okay. When the mitral valve closes, immediately after some time, what happens? There is opening of the aortic valve. So that means S1 will be followed by opening of the aortic valve. Opening of the aortic valve is relatively silent, so you won't get any sound. That means when the mitral valve is closing, that is indicating end of diastole. I hope you understood this. Mitral valve, when it closes, the diastole is over. That means S1 is not only indicating the end of the diastole, but it is also indicating one more interesting thing, that is the beginning of systole. Beginning of systole. That means when you hear the sound lub, what is starting? The systole is starting. So I will write here SYSTOLE. The systole is starting. S2, what is S2? S2 is closure of semilunar valves. One of the semilunar valve is aortic valve. Okay, so you remember this, the semilunar valve is closing here. When the semilunar valve closes, what happens? The blood that was going out stops. That means when the blood is going out, what do you call that phase? That is the systole phase. That is the systole phase. So S1 marks the beginning of S1 marks the beginning of the systole, and S2 marks the conclusion of the systole. So in fact, when you hear the sound lub, that means the systole has started. When you hear the word dub, that means what happened here? The systole is concluded. That means from S2, what is beginning? The diastole will begin. Till when? Till the next appearance of S1. Okay, so between S1 to S2, we have systole of the heart. Between S2 to S1, we have the diastole of the heart. So it's so beautiful. Now, what I'm trying to say is, sometimes you may hear a murmur like this. For example, you hear lub, dub, lub, dub. This is completely normal. But you see this, there is a murmur like that, lub, boof, dub, lub, boof, dub. That means what is happening? Between lub and dub, there is some abnormal rumbling or abnormal blowing or some abnormal hissing sound. Okay, this is called as a murmur. When a sound, abnormal sound you are getting between S1 and S2, what do you call that? It is called as a systolic murmur. Why it is called systolic murmur? Because it is coming in the systolic phase of the heart. It is coming in the systolic phase of the heart. So S1 and S2, in between, if there is a sound, I will repeat once again, lub, boof, dub, lub, boof, dub, lub, boof, dub. That means what is happening here? Between S1 and S2, we have an abnormal sound. That is called as a systolic murmur. And sometimes the diastolic murmur will be like this. Diastole is happening after S2. So here what will happen? Lub, dub, boof, lub, dub, boof, lub, dub, boof. So what is happening? Lub, dub, boof. So what is happening? After S2. After S2. So the murmur is happening after S2. So that's how we can very easily understand whether it is a systolic murmur or a diastolic murmur. Okay, as you keep listening to the heart sounds, you get very easily understand whether you are listening in the systolic phase or you are listening from the diastolic phase. So these are the two important things. Just 1 second. Yeah, sorry for the inconvenience. Okay, yeah, we'll continue and start here. So between S1 and S2 there is systole, and between S2 and S1 there is diastole. So that's how we will be able to understand. And one more thing, once the S1 is over, Once the S1 is over, there is the ejection of the ventricle starts. The ventricles are contracting, and when the ventricles contract, the blood is ejected out. When the ventricles contract, we also feel the pulse. We also feel the pulse. Another simple way to understand whether it is a systolic murmur or diastolic murmur is when you hear the abnormal sound, just remember this one, boof, like that. Okay, there is a blowing sound. Simultaneously, you get the pulse also. Boof, boof, boof. That means when you are able to feel the pulse, it is at the same time you are able to hear the murmur also. When the murmur and the pulse coincide, when the murmur and the pulse coincide, it is a systolic murmur. When the murmur and the pulse doesn't coincide, they are asynchronous. When the murmur and the pulse are not coinciding, they are called diastolic murmurs. They are called diastolic murmurs. Systolic murmurs are highly intensified. That's why they are clearly audible. But diastolic murmurs comes from the passive phase of the heart, so they are less audible, low pitched. They are low pitched. That's why, you know, MacLeod's one beautiful statement will be there. Okay. Now, systolic murmurs are called noise. Systolic murmurs are called noise, but diastolic murmurs are called absence of noise. Absence of noise, or it's a period of silence. What dominates is a period of silence. So in fact, we need to remember that systolic murmurs are more louder, diastolic murmurs are less intensified. They are low-pitched murmurs, but there is one exception. The murmur of aortic regurgitation is the loudest diastolic murmur. It is the loudest diastolic murmur. Okay. So the second point that we are trying to understand is you are finding whether there is any extra heart sound, that is S3. Now, why there is S3? First of all, let us understand here. What is the reason for S3? S3 is called a turbulent noise. Why there is S3? S3 is because of first rapid filling phase. S3 is because of the first rapid filling phase. Now, I don't know whether I should be explaining this or you all understand me better. Just one quick explanation I'll give you. See this, this is the left atrium and this is the left ventricle and the aorta. Now, remember which valve is this? This is the mitral valve. Now, what happened? The mitral valve is open and this aortic valve is closed. So now to understand, I will draw the blood with pink color. So what happens when the mitral valve opens? The blood from the left atrium enters into the left ventricle because of the pressure difference. Here, the pressure is almost 4 mm of Hg. Here, the pressure is 5 mm of Hg. So there is a pressure difference. So what happens to the blood? The blood enters from left atrium to left ventricle. So the first rapid filling phase is exclusively. The first rapid filling phase is exclusively. There is a question here. Loudest diastolic murmur is aortic regurgitation. Aortic regurgitation. Okay, we'll continue here. The first rapid filling phase. The first rapid filling phase is corresponding to the S3. And what is this first rapid filling phase? It is because when the mitral valve opens, because of the pressure difference, that is called pressure gradient. When there is a pressure gradient, blood moves rapidly from left atrium to left ventricle. And because of the turbulence, we hear S3. Now, let us discuss what is S4. Now, after almost 80% of the blood from left atrium is emptied into the left ventricle, only 20% of the blood remains in the left atrium. Now, what happens? The pressure in the atrium and the pressure in the ventricle both are equalized. When the pressure is equalized, what happens? You know, the atrium now contracts. Now the left atrium contracts. When the left atrium contracts, the blood from the left atrium moves to the left ventricle. How much blood? It is only the last remaining 20%. The 20% of the blood that is remaining in the left atrium now moves into the left ventricle with a lot of force. Why there is a lot of force? Because it is corresponding to left atrial systole. It is corresponding to left atrial systole. This is called final rapid filling phase. This is called final rapid filling phase. Remember, this is the reason behind S3 and S4. Now, we will make a pathological diagram here. So, see this. One thing is, this is the left atrium. But now, I am making the ventricle abnormal here right now. What is abnormality in the ventricle? You know, the ventricle is severely hypertrophied. The ventricle is severely hypertrophied. When the ventricle is severely hypertrophied, now what is happening here? The pressure inside the left ventricle is high. So actually none of the blood is coming from left atrium to left ventricle, because the first rapid filling phase happens because of the pressure gradient. Here there is no much of pressure gradient. That's why blood doesn't come. But maximum amount of blood corresponds to the left atrial systole. That means the blood from the atrium is moving to the ventricle only during the S4 phase. Maximum amount of blood because of the effort of the atrium. Atrium is contracting vigorously in order to pump the blood. That's why the blood is coming to the left ventricle. So what will happen to here? S3 will be softer, or it is not audible, but S4 becomes audible. When S4 becomes audible, who is responsible for S4 to be audible? It is because of the atrium. Atrium is contracting more vigorously and it is able to pump. Now see this. We have S1, we have S2, and one more extra sound is added to this, that is S4. Please remember, S4 is always represented in front of S1. Okay, the reason for that, I don't know, I need to explain so much, but yeah, I'll try explaining, no problem. So see this. So we have three sounds. Normally heart sounds are lub-dub, lub-dub, lub-dub. But what is happening here? There are three sounds here. First one is da. This is called da. S4 is heard like da. Lub, dub. Okay. Da lub dub, da lub dub, da lub dub. There is actually a combination of three different sounds. This is called gallop. This is called gallop. Okay. Now who is responsible for this gallop? S4 is responsible for gallop. Who is responsible for S4? Atrium is responsible. That's why this gallop is also called atrial gallop. This is also called atrial gallop. Now atrial gallop, somebody also called S4 gallop. S4 gallop. Now we will draw one more picture here. Here we have a dilated ventricle, severely dilated ventricle, and we have the left atrium like this. Okay, just imagine this is a very abnormal heart, and you will excuse me because quickly we are drawing. So now what is happening when the ventricle is severely dilated? What happens to the pressure inside? The volume is increasing, but pressure is decreasing. The pressure is so much less here because the chamber has enlarged. So when the pressure is so much less, when this valve opens, what is happening? The pressure difference is so much. So what happens to the first rapid filling phase? The first rapid filling phase, not just 80%, 95% of the blood jumps into it. Okay, so much amount of blood is moving. So now here S3 becomes very louder. S3 becomes very, very louder, but S4 is not audible as usual. It is not audible. So now what happens to the patient? We have S1, we have S2, but this is also followed by S3. This is also followed by S3. Now here it is lub, dub, dum. The textbook describes this as dum. Lub, dub, dum. Lub, dub, dum. So there are three sounds. Again, when you have three sounds combination, here again we call it as gallop. But who is responsible for this gallop? Atrium is telling I didn't do anything. Ventricle is telling maybe me, because the ventricle is severely dilated. That is responsible for the decrease in the pressure. Because of that, the S3 component is becoming very louder. So we have a gallop. So this gallop is called ventricular gallop. This gallop is called ventricular gallop. Now, when you have a ventricular gallop, it is also called as S3 gallop. It is called S3 gallop. But you know, some cases where there is an advanced heart failure, it will be S4 followed by S1 followed by S2 followed by S3. All the four heart sounds may be audible. This is a this is a railway track. Okay, so much of noisy heart it is called as. Okay, so here in such patients we have one name is given. This is called a summation gallop. This is called summation gallop. This is called summation gallop, where all the four heart sounds are audible in one place. So this is about the second point that we are discussing. What is the first point that we are discussing? The first point that we are discussing here is whether the first and second heart sounds are audible. S1, S2 are audible, and their character, whether it is loud, whether it is soft, all those things we have discussed. Second thing is extra heart sounds. What are the extra heart sounds? S3, S4 are audible. If S3, S4 are audible, what is the pathology? Okay, generally I want to add one more point here. Up to 30 years of age, up to 30 years of age, audible S3 is normal. Up to 30 years of age, audible S3 is normal. S3 above 30 years of age, S3 above 30 years of age, it is diagnostic feature of left ventricular failure, or also called left heart failure. Okay, so if it is above 30 years of age, if there is a audible S3, it is diagnostic of left heart failure. So that is about the second point here. First point is S1 and S2. Second point is S3 and S4. And the third point now we are going to hear is, this is normal heart sounds, extra heart sounds. Next point comes is additional sounds. When you have these additional sounds are classified as clicks and snaps. Clicks and snaps. Clicks and snaps both are because of opening of valves. Clicks and snaps both are because of opening of the valves. I want you to concentrate here little time. There is something called as opening. No, it's not opening. I will give you another name. It is called ejection click. Another one is opening snap. This is happening now. I told you about opening. Now failure to open. I want you to see this answer in the chat box. Failure to open is which condition? Failure to open is which condition? I'm waiting. Failure to open. Very good. Failure to open is stenosis. So when we are talking about ejection click and opening snap, both are because of the opening of the valves. That means there is a problem in opening the valves. That means the problem is in what is the quality of the problem here? It is stenosis. Now, if there is a stenosis of aortic valve, or if there is a stenosis of the mitral valve, okay, when there is a stenosis of the aortic valve, you get something called as ejection click. When there is a stenosis of the mitral valve, we get something called as opening snap. But easily we can differentiate them. Very easy to differentiate them. Ejection click will be audible in which phase? Now remember aortic valve. When the aortic valve opens, remember when the aortic valve opens, the blood moves from left ventricle to the aorta. The blood moves from left ventricle to aorta. When the blood moves from left ventricle to aorta, the blood moves from left ventricle to aorta during the systolic phase. Yes or no? During the systolic phase. So this ejection click is a sound that is audible during systole. Are you with me? Now let us talk about the mitral valve. When the mitral valve opens, blood from the left atrium is entering into the left ventricle. Now, blood from the left atrium, when it comes to the left ventricle, that is the diastolic phase. That means opening snap will be heard in the diastolic phase. That is the classical difference. And ejection click is heard in the aortic area, and opening snap is heard in the apex. So this is another difference which helps us to understand whether it is ejection click or opening snap. So shall we put one diagram to explain this in a better way? I'll do that. Entire cardiac phase again in a single snap. So here we have the S1 and here we have S2. Okay, now already I have explained that this is the phase. What is this phase? This phase is called systole and this phase is called diastole. I think for your easy understanding, I'll also place another S1 here. This is another S1. This is S1, this is S2, and this is another S1. So here we have systole, here we have diastole. Now see here, S1 is because of closure of atrioventricular valve. Here it is closure of semilunar valves. Now see this, when there is a closure of atrioventricular valves, something has to open. Something has to open. At this point, you just see this here. At this point, the aortic valve opens. When the aortic valve opens, it is at this place we get the ejection clicks. Okay. Remember here, S2 is actually the closure of semilunar valves. The closure of semilunar valves will be followed by mitral valve opening. Will be followed by mitral valve opening. If mitral valve opening happens here, then immediately we get something called as an opening snap. Opening snap. So you understand now, the opening snap is actually seen in which phase? It is seen in the diastolic phase. Ejection click is seen in which phase? The systolic phase. So please understand here, the clicks and snaps together, what do we call them? Together we call it as additional sounds. Additional sounds. Now these two additional sounds are click and snap. Click is an ejection click. Snap is an opening snap. Why we cannot call it as ejection snap here? Remember, only aortic valve and pulmonary valve there is real ejection. In mitral valve and tricuspid valve, there is no ejection. Only the blood flows. Only the blood flows. There is no ejection. Only in aortic valve and in the pulmonary valve, the ejection is taking place. That's why it is called ejection systolic murmur. Even in pulmonary, we call it as ejection systolic murmur. But we don't use this word ejection on any other valves. I hope it's clear. Let's move to the fourth point. So what is the first point we have studied? We have to hear the S1 and S2. Second point is any extra hard sounds, that is S3 and S4. Third point, additional sounds. What are the additional sounds? Clicks and snaps. This is the additional one. Now next is a very interesting fourth point, that is we need to hear for murmurs. All this time we are actually worried about this murmurs. So that is the fourth one, that is looking for any murmur. Now remember, the murmurs are categorized into so many types, but now how to, in a simple way, if you want to classify them, see this: aortic valve, pulmonary valve, tricuspid, and mitral. Okay, aortic stenosis, you get systolic murmur. Aortic regurgitation, you get a diastolic murmur. It is same here for pulmonary also. Stenosis, systolic murmur, regurgitation, diastolic murmur. But tricuspid regurgitation is seen in systolic phase. Tricuspid stenosis results in a diastolic murmur. It is exactly opposite now here. Mitral stenosis, there is a diastolic murmur. Mitral regurgitation, there is a systolic murmur. So this is a basic thing that we need to understand. And then one more interesting thing is every murmur need to be understood under following headings. That means every murmur has its own location. That means where the murmur is audible clearly. Okay, an aortic murmur is better audible in the aortic area. Now, one more important thing that you should know is aortic area is present over the aortic valve. That is a wrong concept. Aortic area is not overlying the aortic valve. Aortic area is a place in the chest wall where it is best heard or it is best audible. Excellent, Sarika. It is best audible place is called as the aortic area. But one thing is that aortic area is not present above the aortic valve. I hope it's clear now. So now we move to location is over. Then we have to talk about the radiation. The murmurs also have a radiation. Radiation is the second best audible site is called as the radiation. Then the murmurs also have pitch. They are high pitched, low pitched, all those things. The murmur also has a quality. The murmur has a quality. Sorry, I forgot one more. It is also present. Timing is there. That means whether the murmur is systolic or diastolic or sometimes continuous. That means it is present in the systole as well as diastole at the same time. So this is called as continuous murmur. Then the murmur also has intensity. Just now we were talking about that 5 grades of intensity. Yeah, so that also we need to study. Then we also have some physiological maneuvers. Physiological maneuver. That means some murmurs are better audible during inspiration. Some murmurs are better audible during expiration. Some murmurs get intensified when you clench the hands. Some murmurs get intensified when you sit in squatting position. So that's altogether a separate topic called murmurs. We will not be talking about those things. But anyway, whenever you hear a murmur, you need to categorize this murmur under these characteristics. Every murmur will have the characteristics. Okay. One more thing I think we ignored, that is called as a shape. Murmur also has a shape. You might have heard of something called crescendo, decrescendo. Aortic stenosis murmur has crescendo, decrescendo. Then we also have something called holosystolic. This means uniform murmurs. Another murmur is decrescendo murmurs. Okay, that means the murmur intensity gradually decreases. That is called decrescendo murmur. So that's called the shape. So this is very important. So whenever you auscultate, we are actually listening to the heart sounds S1 and S2, whether they are normal, whether they are high in intensity, or whether they are soft. For example, if S1 is very loud, it actually talks about a high stroke volume. Whenever the stroke volume is very high, the S1 becomes naturally louder. Similarly, S1 is produced because of the closure of the atrioventricular valves. What are the atrioventricular valves? Mitral valve and tricuspid valve. If the tricuspid valve and the mitral valve are stenosed, naturally when they close, it produces more sound. So mitral stenosis, tricuspid stenosis produces a loud first heart sound. But also remember one very important thing. If the mitral stenosis is associated with calcification, now calcific mitral stenosis, the sound becomes soft. S1 is loud in mitral stenosis. S1 is soft in calcific mitral stenosis. S1 is absent in mitral regurgitation. In mitral regurgitation, S1 will be totally absent. So this is what we need to be sensitively doing. So first S1 and S2, then we need to hear extra heart sounds S3 and S4. After that, you need to listen for clicks and snaps. You need to write down. Fourth point is we need to talk about the murmurs and describe them under the following headings. And then comes the last point, that is called pericardial rub. Pericardial rub. Okay. Pericardial rub is seen because of the pericarditis. Whenever there is a pericarditis, always remember the pericardium is a sac which contains minimal amount of fluid. In the initial stages of inflammation, there is more dryness. So what happens when the heart is beating, the pericardial layers rub against each other, producing a very, very classical sound that is called pericardial rub. But there is a classical question that pericardial rub and pleural rub, how do we differentiate? Because both are a very dry sound. I actually tell my students, I learned this from my teacher. They say that if you keep your hand on the ear, and scratch on this side, if you scratch on this side, you hear a dry sound. That is how the rubbing sound is going to be. If you just want, you can try it out. Okay, close your ear with your hand and then just scratch on the other side. This is how it's going to be. Or hold a stethoscope on the diaphragm, you can just scratch a little bit. Okay, then what kind of, so first you should keep the earpods into the ear, then only you can do that. Then you can hear that. That is the sound very similar to the pericardial rub or the pleural rub. But how do we differentiate pericardial rub and pleural rub? It is very simple, because you know that when the layers of the pleura rub against each other, then we get a sound that is called pleural rub. When the layers of pericardium rub against each other, then we get a sound that is called pericardial rub. But you know that we cannot voluntarily stop our heart, but we are lucky enough to stop breathing at least for a few seconds. First, what we need to do, tell the patient to stop breathing for a few seconds. Okay, when he stops breathing, if it is a pleural rub, the sound stops. You will not hear any rubbing sound. But if it is a pericardial rub, once there is a cessation of breathing, if that rubbing sound continues, it is a pericardial rub. So the pericardial rub and pleural rub clinically can be differentiated just by asking the patient to hold the breath for a few seconds. It is not difficult. It is highly possible until unless the patient is in distress. So this pericardial rub and pleural rub has to be differentiated. So again, 5 fingers. Let me tell you this one. The moment you hold your steth and come to the patient in order to auscultate for the heart, you need to follow the 5 steps. Whenever you describe, you always should describe that. I'm just telling to you classically one example. You should describe like this, sir. S1 and S2 audible. S1 and S2 are normal in their intensities. S3 and S4 are not audible. And then you should say, there is no audible clicks or snaps. There is no audible murmurs. There is no pericardial rub. This is how you should describe. Make it a point to write even if it is not there, so that one day when you get those things, you will be ready to note it down. Or sometimes if it is abnormal, if it is present. Now let us imagine we are actually talking about a case of mitral stenosis. Okay, I will describe mitral stenosis right now. If you are seeing a case of mitral stenosis, now in case of mitral stenosis, what happens? Mitral stenosis actually produces a diastolic murmur. Okay, to be very classical and frank with you, it is a mid diastolic murmur. Will it radiate to left axilla? Will it radiate to left axilla? Answer is no. It won't radiate to, it won't radiate to left axilla, because mitral regurgitation radiates to left axilla, but mitral stenosis does not radiate to left axilla. I think it will be confusing. I'll remove this for you. Okay. It doesn't radiate to left axilla. Next important thing is, it is a mid-diastolic murmur. It is a very soft murmur. So what we need to do, you should hear with bell of your stethoscope. Do not use the diaphragm. For mid-diastolic murmur of mitral stenosis, do not use the diaphragm. Please use the bell. Okay. Next important thing, the patient should be in left lateral position. If the patient is lying down like this on the back, ask the patient to turn to the left side. When the patient is turning to the left side, it is at that time you auscultate, you will be able to hear this murmur better. And because it is a left-sided murmur, because mitral valve is a left-sided valve, so here the murmur is audible better during expiration. That's why textbook says end of inspiration. End of inspiration. Okay, the murmur is heard at the end of the inspiration. What is generally described, I will explain to you. Ask the patient to exhale the air. Come on, ask the patient to exhale the air and then hold the breath. Like just I'm showing. Inspire, expire, hold. At that time you need to auscultate. Finish your auscultation probably in 20 or 30 seconds and allow the patient to breathe. After he breathes for a few seconds, again allow him to hold it for some time, because this murmur is better audible in the end of the inspiration or when the patient is holding the breath. So I hope you understood this. So if it is a mitral stenosis, there is a diastolic murmur. It is called mid-diastolic murmur. It is soft. So we need to use bell of the stethoscope. Then the patient should be in left lateral position and he should be auscultated at the end of the inspiration. Anything else possible in such cases? Anything else? Mitral stenosis. Stenosis means failure to open. But if there is a sudden opening, there can be an opening snap. There can be an opening snap. Okay. These are all the possibilities that you find on the mitral stenosis, a murmur of mitral stenosis. Similarly, now when you look at a case of aortic regurgitation, come on, somebody can type, even if it is wrong, doesn't matter. You continue to answer my questions. Aortic regurgitation, you get what kind of murmur? Aortic regurgitation. Aortic regurgitation, yes, it is a diastolic. It is a diastolic murmur. Now, can I tell you frankly, it is an early diastolic murmur. It is an early diastolic murmur. Okay. Now, remember one thing very carefully. It is a regurgitation. It is a regurgitation. That means it has a direction of the regurgitant blood has a direction. See, the blood which is gone into the aorta is now returning back. When it is returning back, it is coming into the left ventricle. It is moving to the direction of the mitral valve. The regurgitant blood is moving to the direction of the mitral valve. Now, where is the mitral valve? On the chest, where is the mitral valve? Where is the mitral valve? Exact location of the mitral valve. Best audible at apex. Now, this point, students get confused. Sir, aortic valve is present in the second intercostal space on the right side, but the murmur is better audible in the apex. Why is it better audible in the apex? It is not that the problem is in the mitral area, but what is happening? This regurgitant jet, the blood which has gone into the aorta now returning back. The blood which is returning is called as a regurgitant jet. This jet of blood is actually traveling towards the mitral area. That's why the murmur of aortic regurgitation is better audible at mitral area. I hope you understood this. Then we have some more specifications. You know, if you want to hear this aortic regurgitation murmur better, just now we said mitral stenosis, left lateral position. What is the best position for aortic regurgitation? A murmur of aortic regurgitation, what is the best position? Patient sitting up and leaning forwards. Very good. Patient sitting up and leaning forwards. And aortic valve is on the left side or on the right side? I think no confusion. It is on the left side. So again, it is end of inspiration. The murmur is best heard in the end of inspiration, breath held. That means the patient after expiring the air, okay, at the at the end of inspiration, when the patient holds the breath, after that you will be able to hear this murmur much better. So this is about aortic regurgitation, but I would like to take some time on this aortic regurgitation, 2 minutes more. See this, if this is the aorta, this is the left ventricle, and this is the mitral valve. Okay, now what I'm trying to do is, I'm just trying to show that this is the incompetent aortic valve. The aortic valve is not able to close. So what happens to the blood? The blood that has gone into the aorta, see this? When the left ventricle pumps, the blood has gone into the aorta, but what happens? This valve failed to close. So what happens? This blood is now coming inside. This is called the regurgitant blood. Now when the regurgitant blood is coming here, see this? When the regurgitant blood is entering here, I would like to draw once again. See this? The regurgitant blood, when it is entering inside, do you understand now? The regurgitant blood is moving towards which valve here? Which is this valve? This is the mitral valve. Now, please understand, when the systole is happening, the blood is moving this direction. When the systole stops, what happens? The blood starts to come back. So what happens? When the blood comes inside, it is already just the beginning of the diastole. That's why the murmur is early diastolic murmur. It is called early diastolic murmur. Now, what happens, actually during the diastole, from the mitral valve also, that means from the left atrium also, the blood is coming outside like this. Yes or no? Now just look at this valve. This is called anterior mitral leaflet. Now, when this blood is coming down like this, this leaflet is moving this way. Okay, this leaflet is moving this way, and this particular jet of blood is moving this side. It is moving this side. So what is happening, this anterior valve leaflet is moving between the two jets of blood. It is moving between the two jets of blood. One is the regurgitant blood hitting this side. Another one, a normal left ventricular filling blood is hitting this side. So what exactly is happening here? So there are two jets of blood hitting the valve on this side. So what happens to the valve? The valve is vibrated from both sides. The valve is vibrated from both sides. This causes a vibratory or oscillatory murmur, which is called Austin-Flint murmur. The second murmur that we see in aortic regurgitation is Austin-Flint murmur. This Austin-Flint murmur, just 1 second, friends, just 1 second, give me 1 second. Okay, yeah, so here, this Austin-Flint murmur is also a diastolic murmur, but it's not early. This is called a mid-diastolic murmur. So here we have an early diastolic murmur and also a mid-diastolic murmur. And there is also a third murmur possible in aortic regurgitation, that is called ejection systolic murmur. Why? Because see this, left ventricle is a very lucky ventricle. In fact, it is not so lucky. Because the blood is coming from the left atrium, the blood is also coming from the aorta. This is a regurgitant blood. This is a normal left ventricular filling. So what happens to the left ventricle? Left ventricle is overfilled. When the left ventricle is overfilled, next time when the left ventricle contracts, what happens to the blood? So much amount of blood goes outside. When there is so much of stroke volume, what happens, here there is a turbulence felt and this causes ejection systolic murmur. That's why when you turn the textbooks, particularly aortic regurgitation, you will find 3 murmurs. One is early diastolic murmur. Second one is Austin Flint murmur or a mid diastolic murmur. Third one is an ejection systolic murmur. So there are 3 possibilities. There are 3 possibilities. One is an early diastolic murmur. The actual murmur of aortic regurgitation is an early diastolic murmur. Okay. Sometimes Austin Flint murmur also is seen. I told you that is because of the valve leaflet, that is the anterior valve leaflet is being hit on both sides because of 2 jets of blood. And then there is also something called as ejection systolic murmur. So here comes the end of today's session. That is describing the different qualities of auscultation. So now I would like to just wait for any questions. If you have any question, we'll answer. Before that, I would like to revise. So whenever you go to a patient for examination, in order to understand what is the cardiac pathology, when you are examining the precordium, inspection is must. We need to look for any scar marks. We need to see whether there is any deformity, also any dilated veins or pulsations. It's compulsory. Then we need to check for the cardiac impulse. This is also called apical impulse. This will actually guide you better. Then the apex beat has to be palpated. Now, apex beat palpation is to be done with the palm. It is generally we keep a hand and then we check whether there is an apex beat is present or absent. If apex beat is present, then you need to locate it with the tip of your finger. Then also find out what is the character of the apex beat. Sometimes it may be tapping, sometimes it may be heaving in nature. Then coming down to the auscultation. When you are auscultating, when you auscultate, we should remember that there are 5 things that we need to remember. First one, whether S1 and S2 is audible. If S1 and S2 are audible, whether they are normal, intensified, or they are becoming soft. Second point is, are there any extra hard sounds? What are the extra hard sounds? S3 and S4 is always extra. The presence of an audible S3, an audible S4 above the age of 30 is always diagnostic of some pathology. So S3, if it is present, we call it as S3 is actually called as the atrial gallop. S4 is actually called as the ventricular gallop. So that we have studied. So then we are coming down to the next important additional sounds. There are 2 things classified in additional sound, either a click or a snap. The click is used basically at the aortic valve. Ejection click. It is seen in aortic stenosis. Snap is an opening snap that is seen in case of mitral valve stenosis, mitral stenosis. Okay. But anyway, additional sounds are produced generally because of opening, not because of closing. Normal heart sounds are produced because of closing. Abnormal heart sounds are produced because of opening. That is additional sounds, basically opening snap and ejection click. Once the clicks are over, then we are coming to the murmurs. There are several types of murmurs. Most importantly, the murmurs will have 7 characteristics. We need to describe them under all those characteristics. Then finally, we need to see whether there is any presence of pericardial friction rub. If the friction rub is present, then we are confirming pericarditis. Also, we need to differentiate pericardial rub from pleural rub. So this is the steps of identifying any cardiac pathology. So yesterday we have studied about the different peripheral signs of cardiovascular examination. Today we have concentrated exclusively on the precordium and also auscultation, precordial inspection and palpation, and then auscultation. So majority of the things we have covered. If you have any questions, you're free to raise it up. If I know, I will answer.
Participants, if you have any doubt, please put it in the chat box.
Okay then. So no
Hope-
question. Yeah.
Hope we don't have any doubt. I would like to extend my gratitude to Dr. Rajchandra sir on behalf of SHABDHIKA SFI College Union, Academic Club, and each students of our college. Thank you so much, sir. It was quite interesting way in which you taught each points of precardial examination so that we would never forget this. Again, we would like to hear from you, want to learn more from you. Hope we can have more sessions with you, sir. Thank you all the participants for your patient listening and wonderful responses. Thank you, Dr. Deebu sir and Dr. Russell sir. Our next session will be soon announced. Until then, take care. Good night, everyone.
Okay, thank you so much.